So now we have to ask a question for the IQC sample. Do the 3 lines, do the 3 points, do they form a straight line relationship? And is that straight line parallel to the standard? These are the 2 important criteria for a valid assay that means it's safe to compare, in this case the IQC, with the reference material. Is it a straight line? Is it parallel to the standard? So we now need the best straight line, and the question, is that parallel to the standard? Is it a straight line? Yes. Is it parallel to the standard? Yes. Is every point exactly on the line of best fit? I don't think so, but very close. And again, this is a feature of the assay that even a very small difference, 1 or 2 seconds, can start to move this line substantially in terms of the location on the graph paper. So we need to take some care in the plotting. So this is the IQC sample. Straight line, parallel to the standard. Now we need to make a comparison of the relative concentration. What is the concentration in the IQC relative to the reference or standard line? How do we do that? We look for the point where the straight line through IQC material, we'll look for the point where this cuts through the 100% line. Of course, it's on or close to that clotting time if the assay has been successful. It may not be exactly on that clotting time, but it's normally, of course, very close to it because we've got a straight line and parallel relationship. So we need to know which is the clotting time here where the IQC line cuts 100%. And in this case, 62.46, around that 67 seconds. And then we ask a question, which is the concentration of the standard which would have clotted in 67 seconds? And the simple way to ask that question is to take a horizontal line from this point where it cuts to 100% and look where does that clotting time occur on the calibration line, and that's here. And then we drop a perpendicular and ask the question, what's the concentration of standard which would have given that clotting time? 100%, 90%, 80%, 70%. How many gradations between 70 and 80? 72, 74. So the concentration of the standard which would have clotted at that clotting time, 74%. It means the concentration in the IQC is 74% of whatever is the concentration in the reference. So this has not yet been corrected. This is an uncorrected figure, 74%. It's uncorrected yet. It's not been corrected yet for the concentration of factor VIII contained in the reference plasma. Remember, the reference plasma is usually somewhere close to 100 international units per deciliter. It's usually a pooled normal plasma, but it's very rarely exactly 100 international units per deciliter. It has an assigned potency, maybe 90, maybe 100, maybe 110. It has an assigned potency, which has been derived experimentally when that calibration plasma was assayed against an international standard in a series of experiments, a series of assays, exactly like the one we've just done. That's how the potency is assigned. So we now need to know what is the potency of factor VIII in the reference plasma we've used to construct this assay and this line. The particular reference plasma that we used had an assigned potency of 94 international units per deciliter. It's a pooled normal plasma. It's close to 100, but not exactly 100. 94 international units per deciliter. The concentration of factor VIII in the IQC material is 74% of 94, 69.6, 70 international units per deciliter. What is the expected concentration of the factor VIII in this sample. We need to look at the target values for this particular QC, and we need to know that this value sits within the target. The target range for this particular lot number of QC, 64 to 74. Is 70 within that range? Yes. It means that the assay has been successful. It means that we can proceed to calculations of patient results and that these will be safe to release for patient management purposes. So we need to plot the patient results. Patient number 1, 1 in 10 dilution. On the 100% line, clotting time 81.5 seconds. Here. 1 in 20 dilution. 89.5 seconds. Here. 1 in 40 dilution. 104 seconds. So we now have the 3 points for the first patient sample. Is it a straight line? Yes, pretty close. A straight line parallel to the standard. We put the line of best fit, done visually. It's a straight line relationship. It's parallel to the standard. It meets the criteria for a valid assay. Are the clotting times exactly on the line? No. This is perhaps a second above. This may be a second below. And this is typical. But overall, straight line, parallel to the standard. Where does the line intersect the 100%? It does so at a clotting time around 82 seconds. Which is the concentration of standard? Where is 82 seconds? Here. We drop a perpendicular from 82. 20%. The concentration of this sample, test sample number 1, is 20% of the reference or calibration plasma. So not yet corrected, 20%. What's the level of factor VIII? 20% of 94 international units per deciliter. So that's 19 international units per deciliter. This was a patient with mild hemophilia A, a patient with an elevated APTT. It was around 8 to 10 seconds prolonged compared to the upper limit of reference range. Next patient, 1 in 10 dilution, 67 seconds. 1 in 20 dilution, 70 seconds. Here. 1 in 40 dilution, 78 seconds. Here. So now we have 3 points. It is a straight line, but it's not parallel to the standard. Here is above, and here on or below the line. Straight line relationship, not parallel to the standard. So we have not met the criteria for a valid assay. This sample is a patient who has lupus anticoagulant. The APTT reagents we've used for this factor VIII assay contains a low concentration of phospholipid. It's sensitive to, it's affected by the presence of lupus anticoagulant. So what's happening here? In the 1 in 10 dilution, the antibody is able to prolong the clotting time, a false prolongation. It elevates the clotting time by removing some of the phospholipid sites for the reactions. The reactions run slower, the clotting time is falsely prolonged. So we get a false elevation. As we progressively dilute, 1 in 20, 1 in 40, it's a feature of lupus anticoagulants that we begin to lose that inhibitory effect, and the false prolongation is less prevalent at these higher dilutions. So we move in the higher dilutions closer and closer to the truth, to the real answer, to a clotting time unaffected by this interference. The maximum interference is in the least diluted sample, the 1 in 10. So this does not meet the criteria for a valid assay. So it's not possible to give a fully accurate estimate of the factor VIII concentration. But what we do know is that the higher dilutions will move closer and closer to the truth, closer to the real answer. And if we can obtain 2 dilutions which would give a straight line that's parallel, crucially, which is parallel to the standard, that's an indication that we've diluted away the inhibitory effect. And if that occurs, then I think it's safe to use those two dilutions to make an estimate of the factor VIII activity. In this case, we've got false prolongation with the first dilution. But the other two sit almost exactly on a calibration line. Just double checking the clotting times. Yeah, almost practically exactly on the calibration line. And therefore, both giving a straight line parallel to the standard. So from those two, we could conclude that actually the concentration drawing the straight line is 100% of the concentration in the reference material, 100% of 94 international units per deciliter. So we didn't meet all the criteria for a valid assay. There is interference. I think we're safe because these two show a straight line parallel to the standard, and it's clear that this has a normal concentration of factor VIII. Just keep in mind, why would we be doing a factor VIII assay in a patient that turns out to have lupus anticoagulant? It may be because, most frequently would be because we've seen a prolonged APTT and we want to be reassured that it's not caused by mild haemophilia or mild von Willebrand's disease, perhaps prior to surgery or for some other reason. It's also, I think, an illustration of why we must be really careful in our assay design and why we should not use a single test dilution. Let's suppose we'd made just a single test dilution, the 1 in 10. That would be the normal practice in centres doing a single test dilution. Remember, the clotted time was 67 seconds. If we only had that point and we looked on the standard line, what is the concentration of standard that would plot in 67 seconds? The answer would have been around 74%. 74% of 94, 69.6, 70 international units per deciliter. We would have underestimated the real factor VIII by about 30%, by about 25, 24 international units per deciliter. That's an important inaccuracy. And sometimes that effect is much more marked. We can see falsely reduced levels in the first dilution. So I think it's absolutely the reason why we've got to use 3 dilutions. Turning now to the third patient sample. The 1 in 10 dilution, 141 seconds. The 1 in 20 dilution, also 141 seconds. The 1 in 40 dilution, 142 seconds. First question, is it a straight line? Actually, it's a pretty straight line. Is it parallel to the standard? Absolutely not. There's no differentiation in clotting times at the 3 different dilutions. And now we have a problem. The clotting times are very far outside the range that we've obtained in constructing the calibration curve, which only went up to 78, 79 seconds. So we've got several options. We could go back and repeat the assay and extend the calibration curve to include 1 in 80, 1 in 160, higher dilutions, much longer clotting times, of course, and this would extend the calibration curve so that we could be confident about the linearity of the calibration curve at those lower levels. But we can also draw some information from the fact that we've seen no differentiation in the clotting times from these 3 dilutions. And we also need to remember, what was the blank time? What was the clotting time of buffer alone in this assay system? And that was also 142 seconds. So this patient in these dilutions is giving very similar clotting times to the clotting time of buffer alone. It's highly likely this patient has no factor VIII. And of course, we may have some other information that this was a patient who we know from previous history has severe haemophilia, and it's a patient who developed inhibitor secondary to replacement therapy. So with that information, we've got confirmation here that actually there's no factor VIII present in this patient's plasma. In this case, it's not a surprise. Sometimes, of course, we don't have that information. But if we look again at the calibration curve, if this were extrapolated, and in particular if we had those additional dilutions to confirm the linearity, sometimes it's not present, but it may be, then we can see that the clotting time here would disappear off scale in this opposite direction. And remember, 100%, 10%, 1%. It will intersect the axis substantially below the 1% point. So from putting all that information together, the level of factor VIII in this sample, less than 1 international unit per deciliter. Lupus anticoagulant is the most common cause of this problem of non-parallelism between the patient line and the standard, but there are others. We can see a similar effect if we're working in one-stage assays where other antibodies are present, other inhibitors are present. For example, if we were running a one-stage factor IX assay in a sample from a patient with a high titer anti-factor VIII antibody, this can also show similar non-parallelism. Another occasion, returning to factor VIII assays, if we have a badly collected sample in which there is activation, presence of enzymes, the clotting process is underway before we begin the one-stage factor VIII, then in such a sample, the presence of 10A, activated VIII, for example, this can also lead to non-parallelism. And in this case, we see divergence, so that at the higher dilution, the estimate of potency gets lower rather than higher. We should, in the example we've just used, each of the patient samples were diluted using the same set of dilutions as the standard, 1 in 10, 1 in 20, 1 in 40. Sometimes that's not the case. If the patient is known to be moderate haemophilia, possibly severe haemophilia, we anticipate a low level, then in advance of constructing the assay, we can choose a different set of dilutions. In such a case, perhaps 1 in 5, 1 in 10, 1 in 20. If we know that the patient has expected to have a rather high level, perhaps based on APTT or post-treatment with DDAVP or some other information, then again we can take that into account, and we might choose to assay then at higher dilutions, 1 in 40, 1 in 80, 1 in 160. It's convenient to keep the same proportions, and this way we can plot the clotting times in the same location on the graph paper and make an allowance, a calculation for the different pre-dilution on conclusion of the calculation. So I think we can make use of the prior knowledge to construct carefully the assay design. All of the principles of what we've been discussing is all given in some detail in the sections in the WFH laboratory manual. So I hope that you'll take the chance to access that. It's on the website, as you know, available for free download, and we hope you'll take advantage of that. It's intended as a resource for your use.